All right, all. This is Dr. Derek McClister again, and presentation is Let's Talk About Bunions. Overall, we're going to talk about epidemiology. We're going to define it as best we can using traditional versus 3D approach, the advances, and maybe imaging, and talk a little bit about, once again, radiographs and weight-bearing CT scans, since that's my favorite. When to have surgery is also a topic of discussion for patients, because a lot of patients come in saying, well, my bunion doesn't hurt, or my bunion does hurt, and we'll kind of touch on that. Then what are their patient-reported outcomes? What are recurrence? And then the evidence-based medicine based on my 3 favorite procedures. Overall epidemiology, bunion is one of the most common, if not the most common, forefoot deformity that we will deal with. 2 to 4% of the population will have it over their lifetime. 23% of adults 18 to 65 will have it, and about 36% of elderly or 65 years older or older will have it. So there is a progression with time if we let them continue to have a bunion deformity and they do not get it fixed. There's a genetic predisposition. We all kind of discuss this as being one of the reasons people have bunions. When my patients come into my clinic and say, why do I get a bunion? I say it's probably mom and dad or some grandpa and grandma that have had one, and it's led to this over time for you to have it down your genetic path line. Coughlin described in 2007 that it's at 83% familial history. I always say it's multifactorial because some people have flatter feet, some people have equinus. There's those kind of things that we all talk about that could lead to it. But again, a majority of it is, hey, it's because you were born the way you were born 83% of that time. What is a bunion? Most common complaint is a bump at the big toe joint. So we would see that. We always talk about deviation of toes, things like that. But most people just think of a bunion as that bump on that big toe joint. In my opinion, it's a complex deformity. It's a joint problem. So it's the first metatarsal phalangeal joint. It's a sesamoid complex at that region. Then it's the first tarsometatarsal joint, and then the whole medial column. I think all of those things can affect a bunion, and I think we'll highlight on those throughout this time frame. And then there's additional complexity depending on your foot type, such as metatarsus adductus, such as that flat foot. Things like that also play a role. Here is a picture describing what a normal one would look like, and then what one would look like if you actually had a bunion, and how leads to the next point is that it's also a soft tissue problem. There's extensors, there's flexors, there's the abductor and adductor muscles that do play a role in pathology, and I think we'll kind of hit on some of those down the road. There's questions and changes that have approached. My question, I always say, do we have a consensus on patient, procedure selection, imaging, outcomes, and complications? I kind of always bring these up to patients. So these are the questions I have when a patient comes to me and says, I have a bunion. I always say, well, not every bunion procedure is for every patient. Not every imaging is for everybody. So if you have arthritis, we know you have arthritis. But sometimes people have a slightly tracking joint with some features of arthritis, but we really don't know. And so we might need to get more imaging. Some people have that flatter foot that I've already talked about. Some people have that equinus that we talked about. And we really have to kind of go into those because it can affect how we treat them. It can affect the outcomes, and it can affect the complications going forward. There's 100 plus bunion procedures that have been described, so there's a bunch of them. So in my opinion, that goes back to, do we have the best procedure? Probably not for everybody. There's this old school versus new school. There's traditional versus 3D. I always think that we need to have a discussion in that physical exam. Do we understand patients' goals for satisfaction? Do we try to reduce the joint during our physical exam? Things like that can affect it. Imaging, there's x-rays, the radiographs that we typically use. I use a lot of weight-bearing CT scans, so there's different imaging that people use to define or characterize a bunion. And then there's different outcomes that we've really learned. There's different things that affect recurrence that we've learned over the few years, that this has really been taken precedent on how to get better bunion outcomes for our patient. Traditional algorithm. I think we all kind of learned this in school. I'm not going to go through this table, but this is a very good table describing the old way of thinking about it. Is basically, is there deformity? Is there a hallux valgus angle, IM angle? And then is there a sesamoid position? Is there a distal metatarsal angle? Is there arthritis at the first TMT? Is there at a the big toe joint? Is there any hallux interphalangeus? This table really breaks it down. I think it really goes nicely and is a good basic traditional approach. There's the 3D algorithm, which adds into more of the sesamoid position, that pronation. And I think Dayton and the colleagues that have described this really go into this a little bit more detail. But it's a triplanar deformity, in my opinion. I completely agree with that. And this classification, I think, really helps us kind of talk about, hey, what features our approach to this. I don't know if it directly says that, hey, you have to do this type of treatment, but I think you have to talk about these with your patients depending on their needs. The advances, in my opinion, have started by Okunda. He described that lateral round sign. So with first metatarsal pronation, there is a roundness of the first metatarsal at the distal first metatarsal phalangeal joint. Dayton, EDL, and JFAS really highlighted this even more. They described consistent rounding of the lateral aspect of the first metatarsal head, again going back to that lateral round sign. Again, and it's the increased concavity of the lateral metatarsal with valgus rotation of the hallux. So that 3D deformity coming into play where we can see it. An example of this is where they're using cadavers and they're rotating it, and you can really see baseline. This is kind of that lateral round sign in that medial hallux valgus A portion, and you can see how they highlighted that on that second picture, showing where that lateral round sign can be used to help describe that 3D bunion deformity on just basic radiographs. Advances continued. I think we have all now really highlighted the sesamoids and why these are important. But this is where I say the soft tissues really do play a role. And I think there's a study that'll upcoming kind of show you that this crista may or may not be present. There may or may not have pronation. But realistically, it's bony and soft tissue. And we have to think about it in a 3D way, as well as soft tissue and bone. The study that really got me really interested in weight-bearing CT scans and the bunion deformity was this Kim EDL study back in 2015, level 3 retrospective comparison study. They did a semi-weight-bearing CT scan. Basically, they used a regular CT scan and then they loaded the foot using a device that kind of simulated weight-bearing, but it wasn't full weight-bearing. What they found was that in these bunion deformities, about 83% had first metatarsal pronation. There was about 26% where there was what's called pseudo-subluxation. So it looked like the sesamoids were subluxating, but when they actually looked at it, it was not actually subluxating from the sesamoid crista. It was actually just that rotation, that first metatarsal pronation. And then they really described that pronation was an independent deformity. So you could have pronation, you could have subluxation, but they don't have to go hand in hand. This really got me interested in bunions a whole heck of a lot. That they had this 4-stage classification, and this is kind of what they meant. So no pronation, no subluxation. This is what it would look like is number 1. Number 2 is no pronation, but there is sesamoid subluxation. You can see how the sesamoids are slipping. This is the pseudo-subluxation where they saw about 26% of the time. So they had positive pronation, negative subluxation. So it looks like it's subluxing on the AP radiograph, but actually on the CT scan there wasn't. And then the fourth was positive pronation and positive subluxation. And this is really the table that they put in their paper. This is 2015, you guys. It was the best paper that I read on bunions in a really long time. It really got me thinking about bunions differently when I read this when I was a student, and really highlighted why I wanted to get a weight-bearing CT scan when I was in residency to really get better information for our bunions going forward. Now, if you don't have a weight-bearing CT scan or you're not getting a CT scan with simulated weight-bearing CT scan, what can you do? I think Dayton and everybody has really described that sesamoids are very important based on this pronation that we may see. Siebert EDL back in 2023, Foot and Ankle International really described, I think, whether you can use sesamoid axial views versus a weight-bearing CT scan to describe metatarsal pronation versus subluxation. I'm not going to really go into this, but they compared the two. And what they basically found was that metatarsal pronation with weight-bearing CT scan or weight-bearing x-rays, there was really no difference in finding these. But I think what highlights, and I think the study that I'll show next really classifies it, you can, with a weight-bearing CT scan, get a heck of a lot more information than just a sesamoid axial view. Even though they say, hey, you might be able to still get good information from the sesamoid axial view, I think preoperatively, if you have any question on what the sesamoids are doing, I think a weight-bearing CT scan gives you 10 times more detail. And overall, this is why I'm going to give you this as a shameless plug. Me and my team at my former residence, it really described this, and we did a weight-bearing CT scan, and we took our bunions and we looked at them, and we really evaluated what Kim did in the semi-weight-bearing CT scan, and we really did this on a full weight-bearing CT scan or the curved beam CT scan where you're standing on it, and we get three-dimensional of what you're doing when you're standing and what you're doing, what your bunion's doing at all points in time. So we got this published in 2026. That's a level 4, so it's not super high quality, but we basically did pre-op weight-bearing CT scan for our bunions, and then we also had pre-op x-rays. 64 patients were included because I don't get everybody that has a bunion. If you have arthritis, I'm likely going to fuse your joint. Not every one of my bunions had this. Not all my partners at the time were getting weight-bearing CT scans, so I wish we would have had a little bit more people involved, but again, I did quite a few weight-bearing CT scans on bunions at this time. What I will say is that about 60% of bunions had pronation and subluxation. 80% actually had sesamoid subluxation. So quite a few of my bunions that I see actually had worse subluxation than the Kim EDL. I had less pseudo subluxation. So I had less people with, hey, it looks good on an AP and there's getting subluxation versus, hey, you actually do have true subluxation. And I think the biggest finding that I had, and why I love weight-bearing CT scans when I'm trying to tell my patients what procedures to do, is because if I had questions on it, I got a weight-bearing CT scan. And this is really why. About 60% of them had some arthritic degeneration. So if we know that we're doing bunions on people and they have arthritis at their big toe joint, don't we want to tell them that so we can treat our patients better? And then also at the same time is if a bunion gets bad, what happens to the crista? I found about 50% of the time had some form of crista abnormalities. So 50% of those patients that had bunions, 30 of them basically had some abnormal crista. And that kind of goes hand in hand. As the bunion gets worse, there's likely subluxation, which is going to wear down that crista. And maybe we're not picking the best procedures for those patients. Maybe we should fuse them versus do a distal metatarsalostomy versus a lapidus. And maybe that's why some of our bunions are coming back, or maybe why some people still have pain that we really can't predict. So we concluded that weight-bearing CT scans are the most accurate way of evaluating hallux valgus. We use multiple criteria. I really felt that we've defined that there was a lot of subluxation in the 64% of bunions that we did, or 64 bunion patients that we had, and then relatively high percentage of arthritic changes and abnormal crista. And then we kind of correlated that subluxation of the sesamoids increased with hallux valgus deformity. So as your bunion got worse, there was likely more subluxation that goes with it. And kind of intuitively, that makes sense to most of us. I really like weight-bearing CT scans. I usually get them on most of my patients I'm going to do surgery on, especially any type of bony surgery. And this is kind of highlighting why I would do that. Imaging, there's traditional, and we're going to get IM angle, hallux valgus angle, we're going to get tibial sesamoid position. We always look at metatarsus adductus, or we always taught that you should look at metatarsus adductus. The 3D, we all still use x-rays. The first thing we do when we see patients is we get an x-ray if they come in for a bunion. But I usually get that weight-bearing CT scan, and we get 3D views of this. So we get first metatarsal pronation, we get sesamoid subluxation. I feel like when we are thinking about the 3D pathology, we have to think about instability of the foot, and then we can also add in that metatarsus adductus as well. So my stance on all of these things are weight-bearing CT scan is the gold standard. You get traditional information plus you get first metatarsal pronation information. You also get sesamoid information, and you get details about the medial column. This is an example of a patient that had a flatter foot, had an arthritic type bunion, but really didn't want to have a big toe joint fused. And you can see through this image that there was significant collapse and elevation. So collapse through the midfoot and significant elevation through the midfoot, and then through the first ray, getting jammy at the big toe joint. So if we didn't have the weight-bearing CT scan, we can kind of see this based on X-ray, but we might not get that key details. And then ultimately, this is hard to see, but there was arthritic changes at that first metatarsal sesamoid complex. 2021 described that weight-bearing CT scan was useful in assessing pronation, and it helped guiding surgical management in individual cases. I agree with that. Another study in 2021, metatarsal pronation is a normal variant, so it doesn't have to actually come with just bunions. You can have some pronation or rotation of anybody's foot. So again, not everything is defined through just, hey, you have to have a bunion to get pronation. And then Conti 2020, subluxation was independent of first metatarsal pronation. And I think that really does highlight what we're really seeing on the weight-bearing CT scans. Based on all that information, when do you do surgery on patients? I don't think there's a correct answer overall for this. I think quality of life is key. I always kind of talk about, hey, if you have a bunion, you have to think about how bad your pain is, how bad your ability to do your job is, how bad it is to get into shoe gear that you need to wear. So all those things really affect it. And then also we have to talk about hammer toes and metatarsalgia. A lot of my patients come in, they have a bunion. The bunion doesn't really bug them, but they have metatarsalgia. And we know if that first column, medial first ray is not working well with a bunion and they're getting overload, that there likely is the contributing factor why they're getting metatarsalgia is due to that incompetence of that first ray. So I think about that all the time is when I'm doing these surgeries on patients that I'm thinking about, hey, you have a bunion. You're not telling me your bunion's painful, but you got hammer toes, you got metatarsalgia, you have an Aquinas contracture. I combine all of those things into one, and I do one big surgery, which I fix the bunion at the same time, whether I do a big toe joint fusion and I do MIS, distal metatarsal osteotomies, and MIS hammer toes. I usually don't just do distal metatarsal osteotomies when they have a bunion and metatarsalgia. So you got to think about those associated deformities when they come in as well. But there's no right answer when you do surgery. It's about your patients, how you describe things to them. But I'm quite aggressive when they come in if they start talking about other pain just with their bunion or without the bunion. I usually have certain goals when I talk about patients. I want their toe to be straight. I want it to be a functional joint. I don't want them to have pain. And then I want to have good radiographic findings. And then I also talk about patient goals. So I kind of combine those all into one to kind of get the best information from my patients to help treat them better. Because not every patient exactly aligns with your thoughts. Some people want to have big toe joint motion even though they have a little arthritis, and you really have to talk about that in detail. And then again, there's different patient goals. So highlighting office visit, in my opinion, is essential to deciding on what surgery is best for the patient or what type of procedures you should do. What have we kind of found out based on literature which gives patients the best outcomes? This study in Journal Orthopedic Surgery in 2008 really described the top 3 expectations. They want to have improved walking, they want to have pain relief, and they want to be able to wear shoes. I think most of us can agree with that's what patients want. They're not 100% certain if they need a stick straight toe, but they always want not to have that recurrent bunion down the road, but they want to be able to walk, which goes hand in hand with getting in shoe gears, and they want to have pain relief, which is a good key if we got the joint functioning the way we want, kind of like my surgeon goals that we just previously talked about. Matthews in 2019 described that there was no pre-op associated with radiographic findings. So you can have a bad bunion, you can have a non-bad bunion, but it doesn't really matter because every patient's pain is different. So just because they have a bad bunion doesn't mean they have to have surgery, in my mind. And I think this study proves that. McDonald 2020 there are certain thresholds. So again, I think you have to have a really good conversation in your clinic and your physical exam of why the patients are having surgery. If it's due to pain, they're likely going to have a better outcome. If it's just because they want to get into shoes, they might still have a good outcome, but what if they get a complication? Then they still might be frustrated that there's something else going on. But if it's pain-wise and physical function-wise, there's usually a threshold, and this really kind of helps us if we really look at the PROMIS scores. 2016, a good study found that a tibial-sesamoid position after surgery or before surgery, where they're going to be likely dissatisfied long term. 2021, I think this is a really good cue for all of us, is that, hey, you have to visualize the cosmetic appearance. So if you take a picture preoperatively and a picture postoperatively, and you say, this is what your bunion looked like preoperatively, and now this is what it looks like postoperatively, most patients had actually better outcome and better subjective pain relief and functional improvement. So maybe take pictures preoperatively and then postoperatively so you can compare it with the patient, so they can be like, oh my gosh, my toe is straighter, even though it might not be stick straight the way they want it to. Going into recurrence, literature reports varying rates of recurrence. I think it really is hard to describe one, hey, you're going to get a 10% if your bunion is like this, because there's so many factors like we talked about, whether it's a flat foot, whether it's not a flat foot, whether there's Aquinas related, whether there's not Aquinas related, whether there's metatarsalgia, but you didn't really address the metatarsalgia. But in my opinion, it's all multifactorial. So we either pick the wrong patients to do surgery on, right? Or we pick the wrong procedures to do for those patients. And I think that's why our physical exam, our imaging is key. Why I love weight-bearing CT scans, because we get, one, all the information we want. We can get the flat foot information, we can get the pronation information, we can get the arthritis information, and then you not only see them the first visit, but you also usually see them a second visit to have that deeper discussion. This is a table kind of describing the main reasons for recurrence. I think we've all hit this in school, but there's a good reason, and there's multiple reasons for it. Park 2017 described that, hey, if you have a pre-op metatarsus adductus of greater than 23 or a pre-op hallux valgus angle greater than 40, there's likely an increased chance of recurrence. And then if they described if you have immediate post-op hallux valgus angle greater than 8 or immediate post-op sesamoid position of greater than 4, you're likely going to get more recurrence down the road. I think we all can kind of agree with that, is if it looks like a bunion preoperatively and then you do a bunion procedure postoperatively and it still looks like a bunion x-ray wise, it's likely going to come back at some point in time, and people will probably be a little bit dissatisfied with the recurrence. Shibuya 2018 found that a greater post-op tibial sesamoid position of 4 to 5, they had a chance of recurrence of about 50 to 60% based on those two numbers. And I think most of us can agree with, if you didn't correct the bunion or the sesamoid position from preoperatively to postoperatively, that the bunion's likely going to come back at some point in time. I think what we didn't highlight on was metatarsus adductus, because there's this huge push whether you should be doing metatarsus adductus correction with your bunions with certain types of companies, and a really big hit over the last probably 5 years of doing a metatarsus adductus correction with our bunions if we need to. I think this study by Ayer in 2016 really highlighted that. It's a retrospective review. They talked about radiographic recurrence. Hallux valgus angles without metatarsus adductus was about 15%. Hallux valgus angle with metatarsus adductus was about 30%, so it jumped. And if you had severe metatarsus adductus, it was about 18% of patients. So they did Lapidus with second and third tarsometatarsal joint fusions at that time to try to decrease that. And I think this is where the metatarsus adductus correction 1 through 3 has really played a role, whether you're doing metatarsal osteotomies proximally, whether you're doing something a little bit more more aggressive like fusion procedures. I think there are different choices for everybody, but they concluded that metatarsus adductus does increase the chance of recurrence, and they would say, hey, if you have that, you probably should address this. And then I think Conti et al. Kind of followed up with this 2021 retrospective review comparison series. They concluded that patients with hallux valgus and metatarsus adductus, they may have a worse outcome if they just have a Lapidus procedure only. There's a trend that there's a higher recurrence with just a Lapidus procedure. So I think these are things that you have to discuss with your patients preoperatively, that, hey, you know what, you have a foot type that maybe needs a little bit bigger surgery than the other patient that just had a simple bunion procedure. And I don't think any bunion procedure is simple because of all the things that we've been talking about. But I think we have to just at least address the elephant in the room. If there's metatarsus adductus, you may want to talk to them about doing additional procedures. What else do we think about? We think about instability. Fleming, 2015, described about 74% intercuneiform instability with the hook test. They recommended a spot weld screw, so intermetatarsal screw. What this means is basically is that we want to try to stabilize the foot as much as possible, because there still might be some instability that leads to that splaying of the IM angle and that recurrence. I think you have to have a good idea preoperatively and then intraoperatively when you should be testing these patients, or in my opinion, just think about it first to be J fusion if you're just questioning everything. Phil Meyer, 2017, intermetatarsal screw reduced motion, so the transverse and coronal plane. So really, they describe that, hey, there's ways to decrease instability if you're concerned about this. 2018, they found significant mobility between 1 and 2 intermediate cuneiforms between weight-bearing CT scans. So they found that dorsiflexion was increased, basically. In 2019, they described that hallux valgus associated with basically if you stood on a scan and stepped on it and where your foot is that basically a hallux valgus angle showed instability in people's foot types. So there's reasons why some people have bunions that come back, and I think it's stuff that we have to recognize, whether it be metatarsus adductus, whether it be that they just have a natural foot type. On that weight-bearing CT scan that we can see is that they're a flatter foot. There's rotation of the sesamoids. Maybe they have metatarsus adductus. Whatever it is, that there is different reasons that bunions come back, whether it be metatarsus adductus, whether it be instability, whether it be their foot type, a flatter foot. My stance, really, there's goals. We want to reduce the joints, so we want to get the big toe joint straight. We want to get the IM angle corrected. We want to get the hallux valgus angle corrected, and we want to get the tibial sesamoid position corrected. I think there's plus or minuses for correcting the metatarsus adductus. There's some interesting studies out there talking about doing proximal metatarsal osteotomies and letting them kind of just float. And I think there's different dealers, ways to correct metatarsus adductus if you're thinking about it. Here's a patient, just an example of mine. She was younger. She didn't want to have a Lapidus procedure, so I really just chose to do a minimally invasive bunion. What I tried to do at this time was get the whole first ray in one straight line, and I think it looks much better. Is it a perfect procedure? Only time will tell, but that's what she wanted. Everybody's a little bit different. I feel like in my practice, there's 3 procedures that usually can get the job done. So meet your surgeon goals and your patient goals. I think metatarsus adductus is part of the picture. I think you have to consider fixing when appropriate. I don't think we actually have a defined starting point per literature of when you actually need to do it. So there's a big literature push, or there's a big industry push that is, if you have metatarsus adductus, you need to do 1 through 3 tarsometatarsal joint fusions. And is that correct? I can't say that for sure based on the literature, but I think metatarsus adductus does play a role, and I think we have to be aware of it, and we at least have to discuss it with our patients and talk about, hey, if we don't fix this and we just do a Lapidus, and you're 30 years old, by the time you're 50, your bunion might have come back because there's certain angles that we didn't correct, even though we did a procedure on your bunion. And as long as your patient patients are okay with that and they want a simpler procedure, that's their choice. But at least you've talked to them about that. So don't ignore metatarsus adductus. Don't think that you should ignore it and you're like, no, I don't do that. But I think you have to address it, and then you have to talk to them about it, whether it's right or wrong. And then I think for me, I always talk about instability as a whole foot approach. I talk about it as, hey, you have a flatter foot. Your whole first ray is unstable. Do we have to do an Evans osteotomy through the calcaneus? Do we have to do a gastroc and then do a first tarsometatarsal joint fusion? Or can we just cheat and you're 55, you have already a little bit arthritic changes, and you have all these whole foot approach changes, so you're flatter, you collapse through the medial column, you have pronation through your hind foot. I'm just going to fuse your big toe joint because you're a little bit older. I usually give the patients those options, and then I respect their wishes. If they say, you know what, I want to correct everything because I'm 20, I do the Evans, I do the gastroc release, and then I do a first tarsometatarsal joint. If they're 66 and they don't want to have a big foot surgery, but they don't have arthritis of anything, but they would rather just do one simple procedure, I'm going to fuse their big toe joint all day long because I think that's the best procedure to make sure bunions don't come back. I think evidence kind of tells us that, but that doesn't mean that's the correct thing. So I respect my wishes of my patients. At least that's how I approach it. This is, again, an example of doing a whole foot correction where I did a calcaneal osteotomy, double calcaneal osteotomy. I did a cotton, and then I did a minimally invasive, actually, procedure on this patient because that's what she wanted. But I did a bigger procedure, but she didn't want to lose her big toe joint motion, and she really, in my opinion, wasn't a great... When we talked about doing a lapidus, she was like, well, I don't really want to cheat with that. She said, correct my foot and then fix my bunion at the same time. And we kind of went with a bigger procedure, but that was just kind of our choices more than anything. So there's no right choice. I usually am very respectful of my patient wishes. And again, you guys can criticize this. This is just one example of being a little bit differently and respecting my patient wishes, keeping their big toe joint motion intact, or not just doing a lapidus and kind of hoping for the best down the road. I corrected everything, but also kept that motion that my patient wanted. Here's an example of what a weight-bearing CT scan would look like when you get these 3D different pictures. You can see how the sesamoid is pronated. You can see the impronation, but then you can see how the crista is relatively present, but there's arthritis at that crista. So I always tell my patients, if I see this, I'm going to probably recommend getting a big toe joint fusion. So that doesn't mean I'm right by that, but I just tell my patients that, hey, if you have big toe joint pain down the road, this might be why, and we might be fusing your big toe joint down the road at some point in time. And this is kind of the example of what that would look like on an x-ray. Not horrible, it doesn't look super arthritic, but that sesamoid is arthritic on that crista. What procedures? I think since we know that there's 100% or over 100 prescribed procedures, what would we do? I usually use 3, and that's my stance. I don't really deviate from this very much, but I use a distal metatarsal osteotomy, so I do minimally invasive surgery on select patients. I don't use it a lot, but I definitely use it, and I think it's a great procedure for the right patient. I do a lot of first tarsometatarsal joint fusions or lapidus type procedures, and I think that's a great procedure for foot structure related issues, for big 3D reconstruction. So if you got metatarsus adductus plus a bunion, it really helps get you you're already doing the midfoot work. Why don't you just do 1 through 3? But my thought is a lapidus type procedure is a very good procedure. And then in my neck of the woods, a first metatarsal phalangeal joint fusion is my workhorse. A lot of my patients are 40 or above, and they have arthritis, whether they have a flat foot or not. I don't really care about it if I'm going to fuse the big toe joint. And I do a lot of big toe joint fusions, and my former partner does a lot of those as well. And then my other partners are a mix of all these. So everybody's a little bit different. I don't think there's a right choice, but this is my approach. I use minimally invasive surgery as much as I can. I also use a lapidus procedure. I'm starting to do a little bit more minimally invasive lapidus, and I also am doing minimally invasive first metatarsal phalangeal joint fusions as well. But these are my workhorses. Whether you're doing it open or not is up to you. So what does the evidence tell us about certain procedures, and I'll kind of highlight these and these roles, and we can kind of just go through these. So this is a randomized control study, pretty high level of evidence, 2021, level 1 comparison study. They did 22 open versus 20 MIS chevrons. They found no significant difference between patient-reported outcomes, radiographic outcomes, range of motion, or arthritis concerns. They concluded that MIS has comparable outcomes. And so this is one of the studies that has at least decent follow-up comparing open versus not on the minimally invasive side. There's fourth generation, and there's probably now fifth generation osteotomies because we're all changing these and doing more and more of them. But Lewis et al. 2023 gave us a level 4 retrospective review. They concluded that MIS technique is safe and effective. They have found that there is significant improvement in clinical and radiographic outcomes with minimally invasive surgery. And I agree with that. I find that with most of my patients, they're pretty happy with this. As you can see, there were some other associated procedures to help get the foot exactly where they wanted them. So usually it's not just a standalone procedure when you're doing bunion procedures. Study from 2020, minimally invasive surgery. I think this is Foot and Ankle International retrospective case review. They found that basically IAM angle, hallux valgus angle significantly decreased, which helps reduce the bunion. That's the reason why we're doing the surgery. The CT scan found that they helped correct pronation through supination and adduction. And these are kind of films of it. They used, I would say, not a traditional American approach with fixation, but if you go back many years ago, they used to just throw the K-wire down the first ray and hold that and let that kind of find their own spot. Nowadays, we're putting 2 screws across this to give us better results and hold it where we want it. They found for patient-reported outcomes that they significantly improved. So their patients were happy with this procedure. So minimally invasive surgery has shown to at least be as effective as open procedures for distal metatarsal head osteotomies. And they've shown that fourth generation procedures work well. There's now probably even more updated evidence that I just haven't read recently about more bunion procedures that work for these minimally invasive procedures because it's been pushed so much from an industry standpoint. I think there's a study idea that we could do. You do a weight-bearing CT scan study preoperatively and postoperatively with MIS bunions to see pronation and sesamoid complex with the newer generation techniques. So do we correct the pronation? Do we correct the sesamoid position through MIS surgery? I probably don't have high enough numbers for my minimally invasive surgeries because I'm doing a lot of big toe joint fusions, but this is a good study idea in my opinion, and this goes back to that patient that I did before. This is what she looked like. Sesamoids weren't subluxed, and she had pronation, so I thought she would be a great candidate to just do a distal metatarsal osteotomy based on our own goals, and I think we got the cuneiform lined up with the metatarsal head, and everything is in one straight line, so she's done really well postoperatively. Other than minimally invasive surgery, I think Dayton really led the way, and everybody led the way on first tarsometatarsal joint or the lapidus procedure. In 2020, JFAST retrospective case review, basically they found that if you do a lapidus procedure, you get significantly different measurements. So they found that it was very important. You can get great results with the first tarsometatarsal joint. And I think that's probably the workhorse for a majority of providers out there. It is either a minimally invasive procedure or a lapidus type procedure. They found 1 recurrence in their study, so a very low chance of recurrence. They all had unions. I don't always see that, but maybe my patients aren't as compliant. They didn't have patient-reported outcomes, so they can't really state that everybody did well, but based on all patients had good unions and they didn't have recurrence, that you would assume that most patients are happy. And if you really like weight-bearing CT scan, what does a lapidus do? I think this study really highlights this. This is from Foot and Ankle Specialist, 2019, prospective study review. They had a lapidus done for hallux valgus. They did pre-op, post-operative radiographs and a weight-bearing CT scan. And I'll just highlight this weight-bearing CT scan, more detailed foot alignment. So this is why I like it. You can get a lot of information from a weight-bearing CT scan. And in my opinion, in our previous study, you can get arthritic concerns. If there's arthritic concerns, I usually just recommend a big toe joint fusion because I think long-term that's going to be the best for them. But overall, what they concluded that sesamoids were reduced after a Lapidus procedure, and that by doing the Lapidus procedure, it led to an increased height of the second metatarsal. So it actually lifted the second metatarsal up. So maybe you're going to get less issues with metatarsalgia if you're doing a Lapidus procedure. So I thought that was a pretty good, interesting finding. And then they did this diagram of it. And I thought these are the goals that we're trying to accomplish. We're getting the metatarsal in a good position. We'll get the sesamoid in a better position. And if we can lift the second metatarsal up and not have to do a metatarsal osteotomy, I think we're all going to be happy with that. And then the study kind of highlighted that. Again, Conti has really done a bunch of studies on weight-bearing CT scans. In the 2020 Foot and Ankle International, it's a level 4 case series. They did a modified Lapidus, and they found that it was an effective tool. And they did basically a lot of scientific measurements. They found that there was a change in first ray position, reduction of the sesamoids, but it was not associated with postoperative first ray pronation. So again, independent factor. Pronation doesn't have to be associated with subluxation, and I think my study kind of agreed with that, is that we found a lot of subluxation, and there wasn't a lot of, obviously all the time, first metatarsal pronation. And then correction of the sesamoid subluxation led to correction of the IM angle. So getting the soft tissues and the bones associated with the soft tissues helped align the first ray a lot better. And then, hey, what if you're worried about a younger patient and getting back to activities after a Lapidus? Can we do that? This study, 2016, a little older, but still a good study, retrospective review results. They basically compared to preoperatively, 80% of patients returned to sports. 29% had activities, but they were a little bit less difficult. So they still returned to sports, but they still had some difficulties with it. Participation levels improved 40%. So basically, you got better, but there were still some subset of patients that didn't have full satisfaction. And this kind of goes with that 81% of patients were satisfied. Again, bunions are hard to make people perfect and hard to get everybody to be happy with everything. So I think that really goes back with patient selection, knowing what patients want, knowing what they want to do, and how they want things corrected, and then really just educating them on this. I had a patient more recently that wanted a bunion fixed. And they needed a big toe joint fusion, but she wanted a minimally invasive surgery. We did the minimally invasive surgery. I wish I would have did the big toe joint fusion. So sometimes you have patients' goals that are a little different than our own surgeon goals, and I don't think we should deviate from our own goals, knowing that what's going to make the patient happier long term, even though they might not like us saying, hey, you maybe need to go to a different surgeon if this is what you want, and let them go that way, and that's okay. But again, it's a dealer's choice. Bunions are so common. People want to be able to get the bunions fixed, and we're all bunion surgeons, so we all try to help patients out. But getting off my long-winded talk here is that basically a Lapidus procedure, if you do it correctly, it will result that people can get back to activities, and there's going to be a subset of patients that aren't happy, and I think that we've all experienced that. They basically 80% of patients participated in sports after procedure, and 81% were satisfied. Whether this is exactly the gold standard, I think we probably could update the study with a little bit better techniques that we've learned, and maybe with metatarsus adductus correction or without it, and really dive in a little bit deeper from this study. Now, I do a lot of big toe joints fusions, and I'm okay with that. Some patients don't want it. Some areas of the country may say they're never going to have their big toe joint fused for their bunion. I personally don't find that. Most of my patients just want to get rid of pain, and they're okay if their big toe joint is fused. And basically, doing a big toe joint fusion does correct this. So Foot and Ankle International 2016 retrospective comparison study, they found significant differences in IM angle, hallux valgus angle. Basically, you can get good correction through doing a big toe joint fusion. And don't be shy from that. I think Dayton also has a pretty good study on this as well. But they didn't have any patient-reported outcomes on this study. If your patients want to return to sports, especially younger patients or even older patients or middle-aged patients, can they return to sports? This is a good study on this from 2019, Foot and Ankle International, retrospective review, 50 patients. They found that 48 out of 50 patients were satisfied. I mean, that's pretty darn good. I mean, we would all be ecstatic if we got a test score of 48 out of 50. So you can do a big toe joint fusion. People can get back to activities and they can be happy. So I do this a lot. I'm a big toe joint fusion guy. I have no problem fusing big toe joints and telling patients they're going to be happy with it and they're going to be able to get back to sports. I think position really matters. This isn't a positional study talk. This is just let's talk about bunions so we can dive into the position of making it correct down the road if we need to. But just know that if you fuse a big toe joint, they can return to sports, whether they're older, whether they're younger. And so don't be shying away from that, in my opinion. And then 88% or about 90% return to sports participation, which again, I think that goes back hand in hand, that if they're satisfied, they're probably returning to sports. And then all subscores showed a significant improvement with the big toe joint fusion. And I think this is the study that really highlights to me that whether you're 50, whether you're 34, whether you're 66, if you're active, you have arthritis, you have a bad bunion deformity, that weight-bearing CT scan shows that there's some arthritic concerns. They're going to be satisfied with the big toe joint fusion. They're going to be able to return to sports. So don't hesitate fusing a big toe joint, even though it kind of sounds scary to most patients. So conclusions and questions. I want to conclude that it is a 3D problem in most instances. We have to pay attention to it. I think weight-bearing CT scans can define it. Not everybody has a weight-bearing CT scan, so sesamoid axial views are very important. I think it helps me accomplish my goals and meet expectations a little better. I want to reduce the IM angle. I want to reduce the hallux valgus angle. I want to get rid of the sesamoid pronation or subluxation. I want to get rid of the first metatarsal pronation if it's available, and I want to decrease recurrence. So if I can get the most information from a weight-bearing CT scan, why wouldn't I get it if available in my region? That's just my own personal thought. Doesn't mean that everybody has to do it, but if we know it's a 3D problem, why wouldn't we get the best information for most of our patients so we can treat them better? I think most pre-op hallux valgus, metatarsus, and post-op sesamoid position really affect what we're doing. What matters? New question is, does pronation correction correlate? I think there is a school of thought that if you get pronation corrected, it decreases recurrence and increases outcomes. I think there are some questions related to this, and I think that is really highlighting my paper where we had a lot more sesamoid subluxation than pseudo-subluxation versus the Kim EDL. So I think we have a lot of issues that can arise when we're fixing bunions, whether it be a flat foot, whether it be metatarsus adductus, whether it be their arthritic concerns. So all those things matter when we're fixing a bunion, and sometimes we talk about them, sometimes we don't with our patients. But I think, hey, if you have a patient come in, they have a bunion, it's not just let's just fix the bunion. Let's do a deep dive on their foot structure. Let's do a deep dive on pronation. Let's do a deep dive on arthritic concerns. Let's do a deep dive on sesamoid rotation, and then do a really good physical exam to match that so we can get better outcomes for our patient. I think this really hits into the instability. I treat the whole foot all the time. My younger patients get a lot more of a well-rounded foot procedure if they have bunions versus the people that are 66. They might just get a big toe joint fusion. If you're 20 and you come in, you got a flatter foot, you got a quinus, and you got a bunion, I'm probably doing an Evans osteotomy. I'm probably doing a gastroc release, and I'm probably doing a calcaneal, a lapidus type procedure on that patient. And then the questions I have, is there a subset of patients that we will not help either way? Are there people that and I think we've all had them, and good or bad, is that they want something that is normal, and we will never actually make it normal, whether it be their joint function, whether it be their foot structure, whether it be, hey, they have arthritic concerns that we just can't change because it's already been going on for 20 years. And I think that really preoperative exam, that preoperative x-ray, that preoperative CT scan, and then obviously me really liking literature is maybe if we're doing these promise scores, knowing that there is a threshold that if you don't meet the threshold, why are we doing a bunion procedure on you? You're really not going to be satisfied with us after doing the bunion procedure. So just kind of have that in the back of your thought. Just because they have a bunion doesn't mean you're going to always make them happy if you do a bunion procedure. And so patient selection and education is key. I really thrive on this. I really try to be a good doctor in this way. Doesn't mean I'm right all the time, because I definitely am not right all the time, but I try to really dive into this for my patients. And then I think really surgeons and patients can discuss options. And in my opinion, there's 3 different options. Minimally invasive surgery, so a distal metatarsal osteotomy, a Lapidus procedure, and then there's a big toe joint fusion. And I think there's associated procedures with that. Like I said, do you correct the flat foot? So do you do a Evans? Do you do a gastroc release? Do you fix other issues that are going on with the patient at the same time? And that's really you guys doing your physical exam and knowing your patients better than me just telling you that's how you do it. But those are things that I think about. So my stance is twofold. Get a weight-bearing CT scan if it's available. Do a really good physical exam. Have them come into your office a couple different times. And then really talk about 3 different options. Minimally invasive surgery, whether it be a distal metatarsal osteotomy or Lapidus if you're going that route, and then a big toe joint fusion. And that's really kind of how I approach most of my patients, and kind of go from there. And I really have, hopefully, deep conversations about goals. I'm not always right, guys. I'm not saying that this presentation is 100%, but I hope it gives you enough information to make better choices for your patients. If you have any questions, reach out from mcclister@gmail.com. Follow me on Instagram. And then a disclaimer, I am an Arthrex consultant, but this shouldn't have any conflicts of interest in this presentation. All right, guys, have a great day. Let me know if you need anything.